really good, yeah.
It is. It's really good, and it's I was also surprised at the size of it. It's very.
Yeah, it's a big conference.
Yes. Yes.
I'm Bibi from the MCDDA.
A little bit.
This is a consent form.
Because that's recorded.
It's been recorded all the time, the main stage. So if you could please write your name and sign.
Okay. For recording. Thank you. This one.
Okay, we already have.
I'll use someone else's. It's fine.
Yeah.
All right, thank you.
I will be showing cards. You're sharing the session.
Yeah.
I will be showing
Us
cards.
too, yeah.
The green one is when 5 minutes are left, yellow 2 minutes left, and the red one means time is over. Would you like me to insist, or you prefer to do this as shares, give more flexibility to its presentation?
We've got 5 minutes for questions, so I think if it's like time's up and then they can finish off for like just to the last minute or so, but if it gets to like another 2 minutes after that, then maybe like
so I don't need to show neither the 5 minutes left?
Oh no, you still show it, but I think
I'll show you, but then leave it up to you.
Yeah, do you think?
Yeah. Yeah.
So we have some flexibility.
I think it'd be good if the speakers saw the 5
I
minutes sign.
will be sitting in front of the speakers.
Okay,
Okay, thank you. May I take the phone?
Thanks.
Thank you.
Thank you.
Right, thank you. Excuse me.
Yeah, it's not been going for that long, Lisbon Addictions.
What?
It's not been going for very long,
Really?
but it's been really successful every time I've been. Really enjoyed it.
Yeah.
Yeah.
And I know there was the international policy meeting before that.
Yeah.
Which I'm sorry I wasn't invited to that. That would have been a nice one to go to also. So.
Huh?
The international policy meeting that was held the day before.
Yes.
Yeah. So I
wasn't there.
I wasn't there either.
No, me neither. I knew it was happening, but I ended up covering.
But we did the iCannToolkit before Lisbon Addictions last time, and it was full day. When you're doing those workshops, you have to organise everything. So this is all, like we just had the MCDA help us out. It's all kind of managed by them, but when you're doing it yourself inside of it, it's so much work.
It's 450.
Yeah.
450.
It's a lot, yeah.
It's time?
It's time.
Yeah, it's time, yeah.
Are you taking questions at the end or after each
Maybe
meeting?
organize for us, but I mean, we can also amend this.
Oh.
What we do is we have 10 to 15 minutes of questions, then we can have a couple of minutes of questions, then we should have 10 minutes at the end for questions. I wonder whether, would you prefer having all the questions at the very end, or are you okay to have a couple of questions after each presentation? Do you have any preference?
I'm the last, so I'm happy with everything.
Okay.
But it's farther.
Because otherwise he
Yeah.
winds up getting pushed.
I mean, if you
you don't know what
it's good to have a couple of questions because otherwise most of the questions go for the last presentation.
So a couple of questions and then time at the end for final
No, we
discussion.
say all the questions.
Just so you know that have all.
Mr. some big questions there.
Okay, fine, yeah.
Yeah? Are you comfortable with that?
Yeah, fine, yeah.
Let's do that. So I'll just communicate this one.
Hi.
Okay. Welcome everyone, good afternoon. Thank you for coming. Today we brought together a group of international experts to discuss a very timely topic about how to standardize the measurement of cannabis exposure, which we've seen that it's been a topic in a number of different sessions today actually. It is a very challenging area of work that is very rapidly moving forward, particularly with the rapid changes in cannabis products that we all have been observing in the coming years, in this past few years. So today we aim to come together and overview recent evidence-based approaches for the universal measurement of cannabis, cannabis measurement. So we're going to overview the standard THC unit, the International Cannabis Toolkit, the standard joint unit, and our goal is really to integrate multidisciplinary evidence on the consequences of medical and non-medical cannabis use. We will outline why these approaches are a vital step to advance our understanding of the risks and benefits of cannabis use and the implications for public health, research, and for treatment. So finally, we will overview the creation of the standard drinks and how this has paved the way for standardizing measurement of cannabis use. So the first presenter today is going to be Dr. TomFreeman. So Tom came here from the UK, and he's senior lecturer and director of the Addiction and Mental Health Group. This group is an interdisciplinary research group that bridges departments of psychology and life sciences at the University of Bath. Tom is internationally known for his research on cannabis and cannabinoids. Today he will present on the development of the standard THC unit to measure cannabis exposure across different products and routes of administration. So thank you, Tom. Looking forward to hear from you.
Thanks very much, Valentina, and it's really a pleasure to be here in Lisbon again. So thank you very much to the Scientific Committee for having us here, and it's really a pleasure to speak to you about our work. And we've seen such drastic changes in cannabis products in recent years, differences in potencies, changes in different markets, and different routes of administration. And it's really important to try and map that all with a granular approach. We need to start developing more intensive methods of measuring cannabis use. But alongside that more granularity, we also need to think about single standardized measures that cut across all cannabis products. And this is the kind of work I'm going to speak to you today about with the standard THC unit. So thinking about the problem more broadly, we know that the health effects of drugs relate to the dose, and often in surveys and in clinical settings, people consider the frequency of use. It's very easy to ask somebody the frequency of drug use. But we do know as well it's very important to consider the quantity. And I can give you an example in relation to alcohol. If we have two individuals here, both of them report drinking alcohol every day. So if these people were to present to clinical services, a healthcare provider might want to find out a bit more information. And we might think, just at a basic level, daily alcohol use could be seen as a risk factor for problematic use. So we'll ask a few more questions. And it turns out that the first individual consumes just a single shot of vodka per day, whereas the second individual consumes 4 shots of vodka and drinks a whole bottle of wine. I don't think vodka and wine go together very well, but that's just this individual's choice, and there are many other different ways in which people drink many different alcohol products. The thing about alcohol is that we can look at dose in a very standardized way. So the solution here is standard units, and in the UK, which is where I'm from, the standard alcohol unit is 8 grams of alcohol. This is good because we can apply this across different drinks, including cider, wine, whiskey, and other spirits, beer, and alcopops. And the really helpful thing about this in a healthcare setting is that we can give guidance about safer use. So in the UK, the recommendation is for men and women not to exceed regularly 14 units per week. And with this in mind, we can see that the first individual is within a safer limit, 7 units per week, whereas the second individual is consuming 98 units per week, so a very high level of use. And so you can see here, accounting for quantity as well as frequency, provided a lot more information about the risk of harm. So that's what we have for alcohol. Now, moving on to cannabis, where things are a bit more tricky. So we have our same 2 individuals reporting daily cannabis use. Again, we think this could be a marker of problematic use, but we're not completely sure, so we asked some more questions. And let's just say, for example, the first individual consumes just a quarter of a joint to help them sleep at night, a very small amount of cannabis, whereas the second individual uses 3 joints per day, 2 dabs, and 2 gummies. So here what we have is a larger quantity, and if I was to ask the audience, does this individual have a level of use that could be problematic? You can put your hands up if you think they do. You can see some hands. And then what about people who think it's not problematic? Hands up. Less support there. And what about people who say we can't say for sure, we don't know? Okay, so that's the right answer. Thanks for that. We don't know. A diverse range of products, different methods of use, and no standardization. And the kinds of cannabis products being used in these methods might vary. So, for example, the dabs of concentrate might be a product of 70% plus THC. The joints might be a herbal product within the range of 15 to 20% THC. This might vary depending on where the cannabis is being used and which product is purchased. It's a very complicated issue. And then we also have the gummy, which is via an oral administration route, very different. And we could also have vapes. So lots of different ways in which cannabis can be used. Now, this is an area which many people have been looking at, and we agree this is an important issue. So this was the number one recommendation from the NIDA Cannabis Policy Research Agenda, was to develop a standardized measure of cannabis use. And you'll hear from Susan more about this later. And also from Antoni Gual, research on the standard joint unit, which has been instrumental for measuring levels of THC in cannabis used in Europe. Overall, the lack of standard units has really hindered our understanding of the health effects of cannabis, and is a key priority to address. And in the work that Valentina and I published, we had two key recommendations for a standard THC unit. The first is that it should reflect the dose of the primary pharmacological constituent, which for cannabis is THC, and so this should be measured in milligrams. In the same way as for alcohol, we have standard units measured in grams. And then the second is that it should apply to all different cannabis products and methods of administration. In order to be universal measure, we felt it was important that the standard THC unit could apply to all different cannabis using occasions. One of the most difficult things building on those principles is deciding how large the standard unit should be. Of course, it could be too low or too high, and we want to find just the right level. If the unit is too low, this is a risk because it won't be seen as a meaningful unit of consumption. We know that it's important that the standard unit is feasible and acceptable to people who use cannabis. If it's too low, it won't be seen as a useful way to track their use. But at the same time, there's a risk if we set it too high, it could encourage people to consume this as if they consider it's a safe dose. The safest level of use of cannabis is none at all, but at the same time, when you have a standard dose, it might encourage people to think that that's an acceptable dose for them to take. So we have to balance out these two competing alternatives. So one really important thing to do is to look at typical use. And we can see research and ecological studies have shown some variety in terms of THC doses. We would want to look not at the typical dose, but actually below this, because this will encourage potentially safer levels of use, but not so low that it's not a feasible level for consumers. And we can also look at experimental psychopharmacology studies. These can tell us really good cause and effect relationships between the effects of different doses of THC and adverse effects. And what we found in literature is that there's this really good window between 2 to 8 milligrams of THC, regardless of route of administration, where you can see a dose of THC can be intoxicating, but without this risk of adverse effects amongst infrequent users. And so right down at the 2 milligram level, this won't be intoxicating for many individuals. It will just be a very, very small increase for some people, up to 8 milligrams, which is more intoxicating. We thought this was a good window to look at for the standard THC unit. And we could go right in the middle and say 5 milligrams, but we could also think about policy implications and how this will integrate to existing frameworks. And it just so happens that in the USA, in particular states and also provinces in Canada, there are regulations about edible products that relate to a maximum of either 5 or 10 milligrams per edible serving. So we thought that overall, combining all of these considerations in terms of experimental studies, public health, feasibility, and policy, the 5 milligram standard THC unit was the best level to set. Which sounds very nice, but there are some problems, and I'm going to speak to you very clearly about them, some of the main limitations that we thought we should mention. The most important one is different methods of use produce different effects, and we can't shy away from this. It's a fact that cannabis is very different to alcohol in this respect. This is a really nice study by Marilyn Huestis' group, where they administered the same dose of THC, 50 milligrams of THC, via a range of different routes, including smoking, vaporization, and oral administration. And you can see on the left, inhaled THC is very much the same if it's inhaled via a joint or a vaporizer. You see this rapid onset and rapid offset of effects, peaking at around 60 minutes there. Whereas for oral THC, we see a very slow onset and slow offset of effects, peaking at around 3 hours. So we can't say they're the same. Definitely these routes of administration are different. One thing we can see is that the peak level of high here, around 40 out of 100, was similar for these different methods of use. So what we think we should do is take the standard THC unit as a tool to measure differences and explore differences in routes of administration. We shouldn't say they're the same, but for consumers, we can say that the same dose can produce a somewhat comparable effect in terms of peak high when administered by oral or inhaled administration. And then another major limitation of the standard THC unit is other cannabis constituents. And I've done a lot of research on cannabidiol and whether this could influence the effects of THC. I've done a systematic review of this recently, and also last week there was a study published, the most robust and large study to examine this was the eCBD study, which tested a range of different CBD to THC ratios, the kinds of ratios found in both street cannabis and medical cannabis products. And what we found was that there was no evidence that CBD influenced the effects of THC at these levels. So whilst I think this is an exciting area to look at, and we were interested in CBD units as a potential avenue to explore, the evidence so far suggests that CBD might have some effects, but possibly negligible, and best to focus on THC for now. So when considering the limitations of the standard THC unit, this was a quote that I found helpful. And actually, this is a quote that Susan Weiss mentioned to me first. Don't let perfect be the enemy of the good. And when I looked it up for my talk, I realized it didn't come from Susan originally. It came from a French professor called Voltaire. But I think this could be a really useful thing to consider when looking at this issue, because we could try and make the perfect unit. We could have lots of intricacies, different units with different routes of administration, cannabidiol, tobacco use, and then suddenly we would have something that's far too complex to ever use. So I think it can be good to have a simple solution and not to let this desire for perfection to hinder progress in this field. So overall, the standard THC is not perfect, but it does have potential to be good by increasing consistency in dose, and this can be applied both to research and also policy and practice. And we published our paper in Addiction back in 2019, and these debate pieces are followed by a series of commentaries. We didn't know how our work would be received, but we had 4 excellent commentaries from around the world, 2 from the USA, 1 from Canada, and 1 from the UK, and we were really happy with the support we had. All of the commentaries did support this idea, gave helpful feedback, and it was really nice to see some consensus in the field that this could be a way to move forwards. And in particular, the commentary from Susan and Nora Volkov was instrumental for progress in this area, because it led to a call for evidence and then a requirement for all investigators funded by the US National Institutes of Health to measure and report research using the standard THC unit. And this is really important because a major funder like this can then influence wider addiction research, policy and practice. And it's also been endorsed by the APA and the College on Problems of Drug Dependence. So in terms of reporting the unit, here's some guidance, a summary of the guidance from the NIH. And it includes points such as a THC unit is a formulation containing 5 milligrams of THC. It applies to both natural and synthetic THC formulations. It is specific to THC, so it doesn't apply to other cannabinoids such as CBD. And it should be used to report a dose of THC administered to participants. Pharmacokinetic parameters can be reported in typical methods. And as an example of how we can report this, again from this recent study published last week, each cannabis dose consisted of 10 milligrams of THC, which is 2 standard THC units. And this is important within the experimental field because lots of studies report doses in different ways. So some studies would report the dose in terms of cannabis. They may or may not report the potency. Some are weight adjusted. There's a lot of variation. So having a single metric can really help with systematic reviews and meta-analyses. And as we move forwards, consistency can be gained from experimental studies, but also observational studies. And we can see how they can map together and help us to understand both the benefits and harms. So in conclusion, the lack of a standard unit for cannabis has really limited our understanding of benefits and harms. The standard THC unit we propose is a low dose of 5 milligrams applied to all products and methods of use. Reporting a THC unit can increase consistency and facilitate data synthesis such as meta-analysis and strengthen the quality of evidence. And ultimately, we hope this can be used to inform the public and healthcare providers about safer levels of use. I'd like to thank Valentina Lorenzetti for working on this project. It's been great to work with you. The Society for the Study of Addiction for funding my research, particularly this project, and Lisbon Addictions for supporting our session. Thanks very much.
Thanks, Tom, for an excellent presentation. Just to clarify, we're going to have questions at the end of all the presentations, so we have a bit of more time to discuss. So our next presenter is Dr. Susan Weiss, who came here all the way from the US. Dr. Weiss is the Director, Division of Extramural Research at NIDA, which oversees NIDA's extramural programs, operation planning, and trans-NIH initiatives, such as the ABCD studies and other studies as well. Dr. Weiss also serves as a Senior Science Advisor to the NIDA Director and Scientific Liaison to the NIH, HHS, and other federal agencies. Welcome, Susan. It's an honor to have you here, and I'm looking forward to hear about paving the way for improved data collection in cannabis use.
Thank you very much. I really appreciate, can you hear me okay? Okay, really appreciate the invitation, and I really appreciate Tom and Valentina's leadership on this effort. It really prompted some of the work that we're doing and that I'm going to talk about, but I'm going to talk about a lot of the difficulties in trying to implement this standard unit. So first, my disclaimer, these are my views, not the views of the US government, and I also have no conflicts to declare. So as Tom mentioned, we actually had a group of people who we brought in to make recommendations to us on the types of policy research that was needed that NIDA could help with. And we got a list of about 28 recommendations, but the first one was that of constructing a standard unit that would make it much easier to be able to understand what the effects are of cannabis, and also to establish standards for measuring intoxication and impairment. As you've already seen, there was Valentina and Tom's article, and then we followed up, and my director, Dr. Volkoff, also wrote a blog in which she again encouraged the fact that we really need to be able to look at we need to be able to develop a standard unit that we could use in research, and that it would have to be irrespective of the variety of products and the potency. So we did many of the same sorts of discussions that Tom spoke about, pluses and minuses of how do you do this, and every time you get into these discussions it gets complicated, but at the same time we know that there's been a lot of inconsistency in measurement over time, and that's been a limitation in many studies. We're very interested in the effects of cannabis use during pregnancy, and we study cohorts that started in the 1970s and 80s where frequent use was considered to be weekly and the potency was about 3 to 4%. That's very different than what we're talking about now, and so we're not getting consistent findings from study to study. We do know, as Tom said, that delta-9 THC is the main component, and so therefore that makes the most sense if you're going to come up with a standard unit. And we know that it's worked pretty well for morphine milligram equivalents and alcohol. And the goal is to have this adopted more broadly so that we could improve the quality of measurement in a variety of different studies, including epidemiology and observational studies, and so that we could inform consumer choice. But we also know the route of administration is highly variable, and even among people who smoke cannabis, the route can be very different in terms of how much they smoke, how deeply they inhale. We know that there are differences in the constituents besides THC, although I did see that recent paper that CBD itself doesn't seem to be a main contributor. The standard unit may be too small. Daily users may be using more than 100 milligrams a day. And one of the maybe uniquely problems that we're dealing with in the United States, which I'll come to in a second, is the fact that we also now have delta-8 THC products, which can also make a person high and are considered to be weaker than the delta-9 THC products. And it's a complicated pharmacokinetic and pharmacodynamic pharmacology of cannabis. So following from this idea that we needed to do this, we put out a public request for information. We had many follow-up discussions with experts. We presented this to our advisory council, and then we issued this notice requiring all of our investigators to use a standard unit of 5 milligrams for all applicable human studies. And I highlighted applicable in green because I'm going to come to why this is very difficult at this point for many of the types of studies that we support. We also followed up with a funding opportunity to encourage investigators to study the pharmacokinetics and pharmacodynamics of delta-9 THC. So as I know, most of you know, we have a very complicated policy in the United States. We have, on a federal level, it is illegal. And it is, and even the cannabis that's used for research for a very long time had to be cannabis that was obtained from one supplier that the DEA licensed, which NIDA had the contract for. Now, recently, the DEA has reinterpreted the international treaties and has decided there could be more than one supplier, but that's really still kind of getting up and going. There are now 7 approved suppliers of marijuana for research. And at the same time, we have the Farm Bill that passed in 2018, which defined hemp as being the cannabis plant with less than 0.3% delta-9 THC, delta-9 THC. And that is not a controlled substance. And that is, in fact, supposed to be regulated by the FDA, but the FDA has not yet put regulations in place. And what's happened is that now we have many other forms of THC that can be made from CBD, which can be found in hemp. So delta-8 THC, delta-10 THC, and other products are now being used in many different states, and they fall into a legal gray zone. A recent court decision said that they were legal, but some of the states have made them illegal. So they're now pretty widely available. And as you know, we have a number of different state laws, and recently 2 more states have approved recreational or adult use marijuana. But the state laws vary significantly on a whole variety of variables, including marketing, the way product testing. They all require product testing, but there's no standardization. Whether or not people are allowed to use the products in consumption, the taxation and what the taxes are used for, and expungement of criminal records, which is incredibly important because I think if you were here earlier, the expungement you need to really get rid of the person's critical record, because even if they're not in jail, it can be, if it's on their record, they can have problems throughout their future getting student loans, getting places, getting employment, getting even renting places. So at the same time, we know the landscape is changing quite dramatically. The cannabis potency is increasing. The slide on the left is actually from illicitly seized cannabis, and it has gone from about 4% to about 14%, and but that is not the potency of what's in the dispensaries. Most of the dispensaries, the cannabis potency is at least 20%. And then we have these other different varieties in which which THC potency can go up to about 70 or 80%. So in addition to the changing products, we also have changing patterns of use. And this slide illustrates the fact that back in 2002, about 14.6 million people reported past month use, and about 30% of those were using more than 20 days. In 2019, we had 31.6 million people reporting past month use, and over 40% were using on a daily basis. And this is a slide that I borrowed from Jonathan Calkins, in which he was discussing this in great detail, showing that the patterns of daily and non-daily cannabis use are really exploding, and this is not a pattern that we've seen in the past. You can see on the left that marijuana use on a daily or near daily basis has been going up exponentially, now about 40% of users, whereas alcohol consumption has been pretty stable. And if you contrast the amount of THC being consumed, his estimates are that among people who were using cannabis before in the 1990s, they may have consumed 1 joint each weekend night, and given the potency of the joints, they would average maybe 4.6 milligrams per day. But a consumer now that uses daily and that uses something like 1.6 grams per day of cannabis that's 20% potency is consuming 320 milligrams per day. We don't really know the exact numbers here, but the change in the consumption is really tremendous. This is just to show you that we've been lucky because we have not seen great increases in youth that were 12 to 17 years old. This is a study called Monitoring the Future, and it is following children that are in school. But at the same time, we do see decreases in alcohol and tobacco consumption. And we have about 6%, and this has been pretty steady, of 12th graders who use cannabis on a daily or near daily basis. And those are probably, those are the groups that we're most concerned about. And that may be an underestimate because many of the people who are using frequently and who are young are also the people who are dropping out of school. At the same time, even though use is not changing, we do see perceived harmfulness going down among all of the grades, and perceived harmfulness of regular use. Many studies have shown that use is increasing in adults, both young adults and adults, and we don't really have as much data on older adults, but we think that use is going up in those populations as well. And we have many research gaps that we've been really, that we're struggling to fill because we don't have as strong evidence as we would like. And again, it comes down to needing better measures of cannabis exposure, and we need probably biological measures as well as self-report. And this is just to say that prenatal and adolescent exposure are areas that we've been very concerned with, and they've been plagued with the fact that we have inconsistent results and that the results may be confounded by other variables. And we've been struggling to answer this in a number of different ways since the changes in policy have gone into effect. But at the very least, we need to have standard units of measure that will help us make these analyses. There are other factors that we also have to consider, including other substance use and other factors in the environment that would affect risk and protection. So what are some of the measures that are needed outside of laboratory settings to provide granularity and specificity? Most of the current population surveys they're good because they show trends, but they have very little granularity. They're looking at lifetime use, past month use, daily use, or near daily use. We really need to know more about how much, if somebody is using on a daily basis, are they using throughout the day? Are they using just at night? How are they high most of the day? These are areas that we really have no information on. We don't know how much Delta-9 THC is being consumed. We don't know what the patterns of use are on weekends, on daily, and whether or not there are variabilities in the patterns of use by different people. Routes of administration, as I've already said, the products that are being used, the many, many different types that are found now in the States, other constituents besides THC, which may or may not have an impact. And again, for the US, now we're seeing all of these Delta-8 products, and that's not being measured at all, and we really don't know a whole lot about it other than it seems to be a weaker form than Delta-9 THC, but affect many of the same systems. We need biological measures in plasma, urine, and hair. This is particularly true in some of the vulnerable populations like pregnant women and adolescents. We have a large study that's ongoing right now, and we are doing hair samples, and we're finding that the hair samples don't necessarily match with what adolescents are reporting. And the same thing in women who are pregnant. Their urine samples don't match up with what they're reporting. And then we need to understand the reasons for use. You know, are they using this for medical reasons? Are they using this for recreational reasons, or both? So what could we do with a standard unit of measurement? We could achieve comparability across the research studies, including epidemiology and observational studies. And there are 2 large studies that NIH is funding on adolescents and on women who are pregnant and their children. We could determine whether there are safer levels of exposure. I put an asterisk there because I'm not considering safe levels of exposure for women who are pregnant, for children or adolescents, or for those at high risk of mental illness. But there may be safe levels of exposure, particularly in adults. We could determine whether what levels of exposure cause or contribute to adverse outcomes, including cannabis use disorder, mental illness, and hyperemesis, which is another problem that we're seeing in emergency rooms. We could identify meaningful treatment outcomes for cannabis use disorder. Now that it's legal in many states, many people don't want to achieve abstinence. They want to achieve a reduction in use that does not interfere with their functioning, and we don't really, again, know how to measure that, and having a standard unit would be helpful. And we could also determine appropriate doses and formulations for medical versus adult use. In the States, most of the medical dispensaries sell exactly the same products that the recreational dispensaries sell. So there are many people who are using medical products that are very high in THC. Not all. There are people who are really trying not to do that, but the general medical dispensaries are not that different from the recreational ones. So we recently put out a call for a registry. We're trying to get more information about medical use of cannabis. This call has been, this funding announcement ended just a few days ago, but we're hoping to be able to try and collect information and try and harmonize it among what different states and different groups are collecting. And again, I mentioned this ABCD, which is this very large study that we are doing, and this is just an example of some of the measures we're trying to get into fairly detailed information about the types of cannabis that children are using. Of course, that depends upon them understanding what they're using, and we also know from studies from David Hammond and others that many people are really unaware of what types of products they're taking or what the potencies are. And so my final slide is, are we now at the point where there are new opportunities for implementation? Are we in a we seem to be, at least in the United States, in a political environment that's a bit more friendly towards marijuana. Oops, how did I lose that? There we go. You know, our president said that he was willing to reconsider marijuana's Schedule I status. That's not the same as decriminalizing it, but we'll see where that goes. There are many bills in Congress that are aiming to decriminalize marijuana. There's one that just passed, but that's really more about researching marijuana and making it easier even with its Schedule I status. There are different research strategies available now. We can do a lot more with social media surveys in terms of getting detailed information about products and doses and servings. There was a study that came out recently by Carrie Cutler, who did an observational study using Zoom, in which she had her participants take the products that they purchased from dispensaries and use them, and then she could measure some of the impacts of those products. There are limitations with that, but it's an interesting approach. We have a mobile laboratory. Part of this is because one of the other issues that we have between the state and federal laws is that researchers cannot study the state products. They have to use only the products that are available through them that have been DEA approved, and that's been a major, major problem. So one of our researchers, Ken Hutchinson, has a mobile laboratory in which he also has people purchasing products, using the products, then coming into his laboratory and taking physiological and subjective measures. This is also not done on his university's campus because universities are worried about having having dispensary or state-approved products on their university. Marketing research. And I think we really need to do this because we really need to have better consumer education. I think standardized products will really help with that. Right now, most flower products that are sold in dispensaries, they're not sold by the THC level. They're sold by these different ways of marketing them, like Purple Kush and other types of things, which are not standardized even from one dispensary to another. So we have a long way to go in labeling our products and in teaching consumers what that means. And then I think it's critical that we share information among our researchers, our regulators, our consumers, and our healthcare community. Thank you.
Thank you, Susan, for that excellent presentation. Lots of challenges raised, but also really exciting opportunities for this work, and seeing from the trends that you showed how important cannabis is. And our next presenter, it's a pleasure to introduce Valentina Lorenzetti, who is Associate Professor and Lead of the Neuroscience and Addiction and Mental Health Programme and Deputy Director of the Healthy Brain and Mind Research Centre at ACU in Australia. She was recently awarded a 5-year Senior Research Fellowship to map brain, cognitive and mental health outcomes in addiction using global multimodal longitudinal MRI studies and developing internationally standardized cannabis metrics. In her presentation, she will overview the International Cannabis Toolkit.
Thank you. It's great to be here with fantastic researchers discussing something that I've been thinking about for ages, and I'm sure that's the same for the others as well. I remember from about 10, 15 years ago during my PhD, and like many of you, probably anyone who's tried to do a systematic literature review in cannabis use, it's practically extremely hard, if not impossible, to really integrate the evidence so far all together, because people and different labs are measuring cannabis use in very different ways. Of course, it's not that people are, not well intended, but it's actually very difficult to measure cannabis use. And so I think it's really good time to come together and think about this together to move the field forward. The other thing also, I'm really glad to be here because a few years ago, I was thinking about pursuing this research topic, but a few people tried to dissuade me saying, the topic on, cannabis metrics is not a very sexy topic. Probably you're not going to get funding. But I'm very happy that I stick to my guns. I ended up meeting Tom, and who thought exactly like me, and we pushed this forward, and here we are today. So I'm really glad. And so take-home message is stick to your guns when you think about an exciting research topic, and team up with people who think like you, and it's fun to work with. So today I'm going to present on a different framework, a complementary framework to the work that Tom presented, the THC unit, and Tony as well. So it's a complementary framework that we aim to hopefully put out there, so to improve the standardization of cannabis dosage and cannabis use. I have no conflict of interest to declare, but if I have something to declare, is that I have probably ingested a very large intoxicating dosage, pastel de nata, and if you haven't had it in Lisbon, I highly recommend that you get some of that before you go. Right, so the THC unit clearly is a step forward because it's based on, the psychoactive effect of cannabis. Therefore, it's very, very important that we focus on the hard evidence. But at the same time, many labs in the world actually don't have the feasibility to measure the THC unit, my lab included as well. I'm in Australia where cannabis products are illegal, so it's going to be very, very hard to ask people to bring in their own cannabis and measure cannabis potency. So lots of other labs might lack resources or technical feasibility as well. And also for some types of studies, this might not be as feasible. So for example, for epidemiological studies that are really focused on large samples and, where people are tested online, then it might be a little bit tricky to ask people, to post perhaps a sample of cannabis. Not impossible, possibly, interesting areas for future work, but not very feasible. So the question is how we currently measure cannabis exposure. And I just wanted to clarify, since I'm based in Australia, this is a very relevant example. This is where we should be, but this is where we're at. We really are falling behind in this area. So a key issue, as I mentioned before, is that there's no agreed upon international approach for standardized metrics for cannabis use. Measuring cannabis use is complex, and we are lagging behind reality as researchers, particularly as now it's even more challenging because there's many more cannabis products available around, and they keep changing. So this is a little bit of an example of, from a literature review, which is actually not about cannabis consumption or cannabis measurements. This is a review that we did in our team about, imaging studies in cannabis users. But, we always overview the methodology, and, we did a bit of a summary of, actually, this student, Emily Robinson from the lab. We did a bit of a summary of how different studies measure cannabis frequency in this example. So you can see there's a number of different metrics that different studies use, quite different. And you can see in some cases it is relatively easy to compare these two metrics. You can convert days per week to days per month very easily. So in some cases this works. But in other cases, it's actually very hard to understand whether different study findings might be led by different consumption levels, because different studies are measuring frequency in very different ways. So in this example, occasions per week and days per week, we can't really standardize and find out how they are equivalent to one another. So that makes it very hard. This is just one example. I'm not going to go in detail for all the other measurements, just for brevity. So in this specific way, and there's nothing to say about, but clearly it is important to have a degree of subtlety in terms of how cannabis frequency is measured in this case. I'm very confident that it's actually valuable to you to know how many occasions people used in a week, and also to know how many days a week. But then if every study does things in their own way, and there's no standardization, not even of one measure of frequency, then it's impossible for us to integrate the evidence and really make sense of it all together. We have a huge amount of studies that have been conducted in the past, 2 more decades, but actually we can't really make the most out of these studies because people and different labs keep reporting things in a different way. So here is just a bit of an example of how measuring different things, exposure differently might be problematic. So imagine that Tom ate pastel de nata on 10 occasions this week. And then we might have Susan, and Susan might have eaten pastel de nata about 3 days this week, right? So in this case, we actually don't know if Tom and Susan ate the same amount of pastel de nata or as often as each other, right? So this is also another example. So we've gone a little bit more far, but I mean, the heterogeneity in measuring cannabis exposure clearly is not just about frequency, it's about dosage, it's about age of onset metrics. It's actually a can of worms, and it's really difficult to compare findings and make sense of all of them. So the problem with lacking the agreed upon cannabis use metric is for interpreting and synthesizing the multidisciplinary evidence on the health consequences of cannabis use across world regions over time, and as cannabis markets change and as cannabis products change as well. And also, this is an issue that causes a bit of a problem in developing guidelines that are evidence-based, strong evidence that can inform on consumers on health risk of associated with different levels of cannabis exposure. We can't really tell users what are evidence-based risky thresholds for use. So we've decided that with Tom and Chandi also was part of our team, Chandi Indocha, we've decided that a good way to go forward was to, contact the key experts in the field and bring everyone together in the same room and discuss on this topic. What do we think should be the key measurements that everybody should be using, and what kind of framework will work to bring everyone together. So this was at Lisbon Addictions in 2019, and it was a fantastic experience, and yes, it was a really good group of people focused on the same topic. And so we had 2 primary aims. The first aim was to identify and disseminate key challenges in measuring cannabis use from an international and multidisciplinary perspective. And that was very important for us to have an international group of people, because we know that cannabis consumption can change between countries in a very significant way as well. And that also might contribute to the heterogeneity of measures that we have between studies. And the other one was we aimed to launch the development of an international cannabis toolkit, which was we were aiming for it to be a standardized, internationally relevant tool to measure cannabis use in research and clinical settings as well. And so the experts, we contacted experts really intentionally from different parts of the world. And, but clearly in future we can also do better as we move the field forward. And as you can see, some countries where entire continents are underrepresented. And also I think in future it would be good to include more ECRs and also additional women researchers to the team to really move, to make sure that there's a lot of voices in the room and that consensus really is between a diverse group of people. And yes, and the team was multidisciplinary. There were people from epidemiology, academia, clinical psych, and other disciplines in here. And this is a bit the framework that we came up with. It's really not, a defined, a rigid framework. It's more like a bit of a toolkit for people to utilize. And I'm just going to go through the key structure of this pyramid. So these layers are based on the costs. So at the base of these pyramids, you can find items that are a bit less costly. And also, these other parameter is ease of implementation, meaning that at the bottom of the pyramid, you have items that are easier to implement, and at the top, you have parameters that are less easy to implement. At the top, we have the gold standards, and at the bottom, we have universal items. In the middle, we have context-dependent measures, because clearly you would appreciate you can't just use 3 items, and, but also we have to be flexible to different contexts, and different items would need to be utilized for different contexts. So I'm just going to start going through the universal layer. These 3 key questions. Have you ever used cannabis? When did you last use cannabis? And in the past month, on how many days have you used cannabis? And if basically all cannabis studies implemented just these 3 items, these alone, which is really not much, would significantly advance the field and increase in a significant way the integration of the evidence and of different study findings. Different items, have different, uses and purposes. So this one can help just briefly screen lifetime cannabis use. This one can be used alone, for example, in hospital emergency settings, just to understand whether, the person is coming there, is presenting for intoxication from cannabis. And these last items can be used to threshold risky cannabis use to understand whether the participant or the person is meeting criteria for risky cannabis use. For example, as suggested by the EMCDDA, which I think is about 20 days per month, would be a thresholding for risky cannabis use. And combined, also these items can help distinguish, whether a frequent user who is trying to abstain is relapsing or is continuing the abstinence. And of course, the limitation of this layer is that it's superficial, and additional layers are required to measure additional cannabis exposure facets. So the second layer, here we are, is the most flexible of all, and it's about really the detailed self-report of cannabis use, and it's very context dependent, very much. And the goal of this item is really to quantify additional aspects of cannabis use in addition to the universal items. And the expert group recommended to utilize timeline follow-back-based methodologies as they help also with memory aids, but also this is a technique that that is quite flexible. And I'm going to show you how. So for example, a key flexibility that the timeline follow-back offers is that it does have flexible time frames. So basically, different studies, depending on the research question, can use different time frames to obtain the information that they're interested in, or based on the feasibility of what's required and how much time participants can actually be available for, depending on the type of study that is conducted. So past 1 to 2 days could be useful for to measure recent use in intervention or epidemiological studies, to the past 3 months to 1 year when in studies where the researchers aim to track longer histories of use. So for example, in imaging studies or the cognitive studies that we run in my lab, we usually almost kidnap the participants for 1 day. We give them plenty of breaks, but we really want to have detailed history of cannabis use, and we tend to use to measure past month or past 3 months. But clearly that time frame is not going to work for many other studies as well. And this is just a summary of different settings that this methodology can be used in. Another item that has come up, which is quite tricky in terms of the timeline follow-back, is measuring dosage. And we recommended to measure in grams if possible. And of course, participants might not remember how many grams they've used of cannabis plant matter, or grams might not just work for everything. But at least it's good to ask participants information about how much have you used. And if they remember how much, for example, cannabis plant matter they are putting in their joints or in their bongs, that could already be more useful than just counting the number of bongs that they have smoked. Of course, a bong or joints can be very different sizes. And of course, with new products, there's new challenges. It's not just feasible to use grams when you try to quantify vaping, gummy bears, drinks, and another couple of few different products. And I mean, this is just a picture of cannabis shops in Lisbon. If you just go around in the streets of Lisbon, you'll see that it's not just possible to measure cannabis exposure in grams. So this is we have no solution, but I think the key thing is to try and measure and ask participants how they've used. And I think this is already a great starting point. And once we have the data, we at least can look at it, integrate it, and try and make sense of it and come up with new solutions. The top layer is biological measures. It's the gold standard, of course, and there's a number of different measures that were suggested as key measures, and they are ordered as a function of feasibility. So at the top, you have more feasible instruments. So, for example, urine screening kits that give you an answer whether there's presence or absence of THC in urine, and they're a relatively inexpensive and quick measure of cannabis exposure. Of course, it's also a bit of a gross measure whereby you don't have much sensitivity or information about the level of THC exposure. While on the other end, again, I'm not going to go through this in very much detail, but you have the gold standard, which will be measuring the THC level, which is actually in the cannabis product that the person is utilizing. And here there's a number of considerations. So clearly this is quite complex, but the key message here really is not necessarily, the overall message here is that, different tools here, different metrics have different uses, and there's different settings for which these different tools can be utilized to be useful. And we were quite happy to see that this idea of the toolkit and the framework was endorsed by a number of different expert cannabis researchers. And of course, this is not the end. This is just the beginning, barely the beginning. And the next steps are about validating the timeline follow-back methodologies and this framework against across different cultures, illicit and illicit markets over time. We also thought that it would be helpful to integrate picture aids in the timeline follow-back methodology as well, particularly because cannabis products are changing so quickly, and there's so many products right now, so it's quite important to try and keep up with the changes as well. And also new methods of medical and non-medical use. Also, this framework needs to be complemented with more detailed population-level monitoring, such as wastewater testing, regulator seeds-to-sale market tracking data, rather than cannabis loyalty card data, so that we can start monitoring the consumers' habits as well. So in conclusion, the consistent use of the standard THC unit and the iCannToolkit framework across research, public health, clinical practice, and medical settings would be recommended to facilitate harmonizing of international evidence on cannabis use, to understand better the health risks associated with cannabis use, and inform approaches for risk reduction and harm minimization. So the take-home message is, if you're measuring cannabis exposure, just remember to implement these 3 items. And if you have greater feasibility and resources, timeline follow-back methodology and biological measures as well. Thank you very much, and thanks everyone for contributing to this initiative.
Thanks very much, Valentina, and it's really great to see how we can use Lisbon Addictions and the side events alongside it to get these groups together and produce output afterwards. So really nice to see that. Now, our final presenter is Dr. Antoni Gual, who is a psychiatrist, emeritus researcher at IDI BAPS, former head of the Addictions Unit at the Neurosciences Institute, Clinic Hospital, University of Barcelona, and also acts as alcohol consultant at the Health Department of Catalonia. He has coordinated major EU-funded projects in the field of addictions and has been PI of several pharmacological clinical trials. Over to you, Tony.
Thanks, Tom. And thanks, Valentina. I think I was thinking while listening, I have to thank you for giving me the chance to present research from the last century, which is what I'm going to do now. So I'm going back to the 20th century, and it's a pleasure because I tend to say that was the most funny, the most challenging research I've done in my life. So coming back to it, it's nice. I got to know about standard rings in 1985. At that time, Cheryl Stephens, then her name changed to Cheryl Cherpitel, but Cheryl came to our hospital. She was working at the General Hospital in San Francisco, and they proposed a joint study, and we were to measure alcohol in standard rings. And I said, standard what? Because to me, in 1985, standard rings looked like something impossible. And there we are, 15 years later, but still in the previous century, we were publishing our work in standard rings, which is what I'm going to share with you. And I'm going to use the old slides, so you will see how things were published in 1999. And we reached there because we answered two questions. The first was, is the standard ring unrealistic? And the answer was no. And the second was, is the standard ring useful? And the answer was probably yes. There were good reasons to think the standard ring was unrealistic in a Mediterranean country. We have a huge variety of beverages, so finding a standard ring is a real challenge. But on top of that, within each kind of beverage, we have a huge variety of ABV, from 8 to 14 in wine. In spirits, it's 15 to 50, so a huge variety. On top of that, there are very many different patterns of use, and you may argue very well that it's not the same drinking 3 beers alone in 10 minutes than drinking 3 beers in 3 hours with your friends and eating. And on top of that, what made it a bit unrealistic is the tradition of shared use. Here you can see pictures of the bota and purro. The bota is what you take when you go to the mountains with your friends, wine inside, and everybody drinks from there. Let me know how can you calculate the standard drink here. And the purro is a typical thing that you put in the center of the table in Catalonia, and when you're having lunch, everybody drinks from there. So you don't need glasses. Again, difficult to find standard drinks here. But we did accept the challenge, and we did what I described as the most funny study in my life. We did 2 types of studies, to study domestic and public drinking, so drinking in public places, what probably in the UK would say on-premise and off-premise, and to study the home consumption, we went to the supermarkets, and when people had paid their drinks, they found ourselves with a table with cups and bottles, and those who had bought alcohol were approached by us and said, what you have bought here, can you pour it in a glass here, the most similar to the one you will use at home? And then we were measuring what they would be doing. We approached also bars, restaurants, and discos and did the same. We were there, we waited until the waiters served, and then we measured what they were serving. And we did this in 8 different Spanish regions and urban and rural settings, and more than 10,000 observations. So as you can imagine, that was a lot of work. And what we found, and here you have the slide from the last century, is, I put it easier for you, what we found is that in beers the median was 9 grams, in wine 10 grams, and in spirits 19, almost 20 grams. And that led us to think that the Spanish standard drink was 10 grams. And when you take spirits in Spain, we say you are taking 2 standard drinks. When you look a bit more into the data, you can see, here you have the data for wine and for spirits, wine on the top, spirits below, that the amounts drank at home and in public places were quite different, from 8 to 11, 17 to 20 grams in the case of spirits. So large differences. And when you look at beer, you can see that those differences do not appear when you look at beer in bulk, which was the same, but the canned beer were 3 different sizes, and this taking into account the total consumption of each type led to the 10 grams that you can see in the final column. So those were the main results, and that's the graph we presented. Let me add a bit of color to show you that for beer, the column was quite displaced to the left. For wine, it was also quite homogeneous, as you can see here in red. And for spirits, you can see that it was quite flat. So very difficult to say you have a standard point here. So summarizing what we found, there was no normal distribution of the curves. We found very large differences across regions, very large differences between urban and rural areas, as you can see here in the city size. We also found relevant differences between public versus home drinking, as I stated before, and differences between settings that were also relevant. Drinking in bars, restaurants, and discos, as you can see here, led to different amounts which were quite diverse. Here we took alcohol by volume of 5% in beers and 12% in wine. So if we had added the alcohol by volume variable, the differences would be even larger. So you may well say that a standard drink, given this dispersion, is not possible. But we thought it was worth to establish the standard drink, and we did establish it in 10 grams. We thought it was useful because it's a simple way to measure what otherwise is unmeasurable, and that was helpful. We acknowledge that this is a way of measuring which is not perfect, is obviously at the cost of accuracy, but we want to emphasize that when you ask someone what he drank 3 days ago, again, the source of information is already inaccurate, so it doesn't make much sense to want to be very accurate with inaccurate information. And this allows to get in very short time very relevant information, which is the quantity information on the use of a drug. Has it been useful? Well, as I said, we first heard about it in 1985. We published in 1999. It's been used in primary healthcare now systematically since 2010, and it's been used now in public health statistics, and it's been used since 2020 in public health messages. So I think the message here is we need to wait a long time until we get the information we provide to be widely used, and that's what's going to happen with the cannabis, I guess. This, a few years later, we thought, well, what we did with alcohol, we can do it with cannabis, and that there we started the standard joint study. We finished in about 5 years ago, and we, in fact, we presented here in Lisbon in 2017 and 2019. That was a bit more problematic. Here you have the same problems we face with alcohol, plus the fact that we have multiple psychoactive principles, different routes of administration, and the non-legal condition of cannabis, which made the research much more difficult. And what we did here is that we studied 400 people from 4 different areas, one from the leisure clubs, cannabis clubs, mental health outpatients, and university students. And we asked all those consumers to fill the questionnaire and to make the donation of a joint roll by themselves. And we offered a pen drive with information as a gift for their participation. They were about 29 years of age, mostly males, and 72% with high school studies. And very shortly, because we already published this and presented it here, what we found is that in Barcelona, the amount of THC in the joints was around 7 milligrams, just slightly higher than in hashish than in marijuana. And the difference was relevant in CBD, and I'm very glad of the data that Tom just presented, because it makes less relevant the differences between marijuana and hashish concerning THC. So we obtained this 7 milligrams, which is 2 milligrams more than what is proposed, and this is just what our field research obtained. If I move to the Valentina's presentation, this concept of a standard joint would probably fit very well with the timeline follow back of the Sobels that she was proposing as the detailed self-report. And I would also add that probably if we are able to make it simple enough, it could go down to the universal setting. So that's something we could consider in the future. I think the standard joint unit is a relevant public health tool, and we have published a couple of papers also with the collaboration of Tom and Valentina. And as I said, I think there is a long way to go according to the experience we've had with the standard ring. So in summary, I would say that the experience from standard rings is that they are a useful tool. It takes time to get them implemented, but they are useful. With the concept of a standard ring or a standard joint or the iCannToolkit, we are giving priority to simplicity, ease of use at the expense of precision, and it pays off. So I think we need to acknowledge that. We should give a thought if to define standard rings, standard joints, it's worth to do the kind of field research we've done, or is it better to do it by consensus? I think this is a thing that needs to be taken into account. And the standard units to measure cannabis, I think they have the same strengths, the same weaknesses that we found with the standard rings. And I would agree with the previous speakers that there is a clear need to use standard measurements for cannabis, and we still have a long way to go here. And let me finish by thanking the research group in our center, which is quite wide, but especially 4 people there. First, Mercè Balcells, because she was the one who had the idea and came to my office one day and said, Tony, why don't we do exactly the same we did with alcohol with cannabis? And that was about 10 years ago, so she was quite in advance. Christina, she did her doctoral thesis and did most of the research work for the standard joint. Joan Colom helped a lot in the possibility to go to the cannabis clubs and get smokers and get the donors. That was not an easy task. And finally, Hugo, who is working a lot in what's also been pointed out, and I think it's very important for the audience. I mean, we're facing a situation where we will have to define risky use. And when we talk about risky use, the standard units are something which are necessary. And thanks a lot.
Thank you, Tony, for your brilliant presentation, and so helpful to have this historical perspective with decades of research to help us in the challenges we face. And on that note, I'd like to say that we have plenty of time for questions, so now it's open to the floor to see if anyone has any questions for the speakers.
I don't know if you can turn on the lights so we can see the audience.
Yeah, that would help. I can see one over there.
Hello? Yeah, it's working. Thanks for that talk. That was really interesting. I have a question based on Valentina, your talk. I'm just wondering now with the development of these new other alternative cannabinoid products, what the term cannabis actually refers to. So, for example, if I'm participating in one of your research studies and you ask me, have you used cannabis? If I've used Delta-8 products, but I haven't actually used THC, how do I respond? I think there is definitely some area of confusion around this as well, because if we look, for example, in jurisdictions where, in the US, where cannabis is illegal, but Delta-8 is illegal, there certainly seems to be this distinction between these two products in the legal market, but is there the language used to describe that in this framework?
Well, that's a very tricky question. I don't think there's a specific answer to that, really. I would hope. But I would say that if we use probably an umbrella term, cannabis, to refer to cannabis and cannabis-related products, I think, in my opinion, the best thing we could do is still ask people what kind of products they have been using. So, for example, if we did have participants coming to some of our recent studies that report using, whether it's vaping or just methods of use we're not used to measure, rather than other types of cannabinoids. Usually the gold standard for us is to ask people, okay, what did you use, and trying to map out what kind of products they were using. So the main thing is really to try and keep up with the times and measure with as much precision as possible what people are reporting to us. And I think this is just the beginning. Probably if we start measuring this, probably we can then have maybe over time sufficient data, maybe across different labs. If lots of different labs did that, we might be able to put together a bit of a multi-site approach and try and understand whether people who co-use Delta 8 or other different cannabis products, in addition to standard cannabis products, or only these alternative products, are there different risks associated with that? So I'm not sure whether that answers your questions, but yeah, usually the answer is measure, whatever people have mentioned they'd be using. Yeah, I don't know if you have anything else.
Yeah, I think it's a really big question. What is cannabis? And I mean, what a great question to ask at this session. And I think it's a question that needs to be asked. So we should discuss it, but we could see it as a product that contains THC. And most of the cannabis products we've discussed today contain moderate to high levels of THC and are definitely cannabis. But it gets more interesting when we think about the low THC products and the CBD products which are available on the high street. And in certain jurisdictions, when they contain any levels of THC, they're actually controlled under various drug conventions. So in that respect, from a legal framework, any product containing THC could be seen as cannabis, but whether consumers believe that that's meaningful or if it relates to any health effects is more unclear.
I also wonder with synthetic cannabinoids as well, where they all fit as well in all of this, because clearly there's many of them. They keep changing over time as well. So I think that there's something, again, does it fit in the category of cannabis that by their name is synthetic cannabinoids? They might not include, the same kind of chemical compounds that we traditionally define as, cannabinoids. But yeah, I think that we probably need to be considerate of, these different cannabis products. Yeah.
Okay. Any more questions from the audience? Yeah.
So, do you want to go? All right. Hi, Amir England, King's College London. Thanks everyone for a great session. Really interesting. One thing that struck me, and Tom, you'll remember a few years ago, we were in Vancouver. We went to one of these grey market shops and found capsules of 300 milligrams being sold. And that was the jar that was most empty. And the guy behind the counter said that he took one in the morning and one in the evening. And one of those will be 60 units. And Susan, you mentioned this issue as well, and as the issue of tolerance. So what's the panel's view on this issue? How do we deal with the infrequent users versus the frequent ones?
So I think, yes, I think there's probably quite a lot of tolerance to THC, and we can see that with respect to people who are using these concentrates, and they kind of report the same level of high and the same level of impairment with much higher amounts of THC in their plasma. But I think, and we talked about it, and we wound up deciding to go with the lower standard unit for a few reasons. One is that I think we're sort of more concerned about informing new consumers and novel consumers. Also because I'm at NIDA and we are a public health agency, and we were afraid that if we chose a unit that was higher than that, even though it was never meant to be this is a safe dose, that it would have more of that interpretation. So we're not gonna be able to cover the whole range, but I'm also sort of suspecting that the people who are using all day long and are consuming several hundred milligrams of THC are probably not as worried about their standard units. But but we are missing that. I mean, that's absolutely correct.
We've got another question.
Hi, Peter Omen from the Trimbos Institute in the Netherlands. Thank you all so much for these very interesting talks. I think this is a very interesting topic, and I completely agree that we should come to some forms of standardization regarding this, well, more and more important topic. However, I have a couple of concerns and one precise question, actually for you, Antoni. Thank you very much for your work. I think this is extremely cool to see real life research surrounding what people put in joints. This is extremely important. What I was wondering, you showed the medians of THC contents in these joints. What's the variance surrounding these values? I mean, is there a big difference in what people put in these joints, or is it pretty comparable?
I will not be able to tell you by heart. My memory is that the variance was not that high, especially if you compare it to our experience with alcohol. So, and even with the different samples we were using, the differences were not that high.
Yeah, because what I was wondering is, you know, there's this, you mentioned this huge cultural aspect as well with the sharing of the cannabis products. And one of the things that I'm very concerned about with this whole standardization of dosages, and I actually would like to hear all your guys' opinion about this, like, how about the loss of THC from side stream smoke during these kind of normal use sessions, you know, the in-between moments where a lot of this THC actually just, you know, is lost and not ingested. I was wondering, how do you compare between the different routes of administration? I mean, especially here in Europe, like, what is it, like 90% of people are smoking cannabis, mostly in conjunction with tobacco. Yeah, it just seems like a big hot mess. I'm very interested in how you are going to compare, like, between different routes of administrations, because I think that's very important.
Let me add that one of the things we did with our standard joint unit is that we also made, I mean, the message, the short message would be, maybe I was too quick, was in our country, it was a joint has on average about 1/4 gram of marijuana, 7 milligrams of delta-9 THC, and it would cost about €1. That would be the average. On what you're saying, I think it's very important to reflect on what do we want the measurement for. In the field of alcohol, I think we've learned a lot about that. And we all know that there are very many different ways of drinking. The relevant thing in the end is the blood alcohol level you get. So when you just get the quantity drunk, it's not precise measurement, but we all will agree that if we were just taking into account the frequency with which people drink, and Tom presented a very nice couple of slides in the beginning, that would be absolutely irrelevant. The more cannabis has become used by a relevant number of people in our societies, the more it becomes important to add to the frequency the quantity. And then you need to find simple ways to measure quantity. And I think that we all agree that the standard measurement helps a lot to measure something that is not measured, and we all will agree that it's an imperfect way of measuring.
Yeah, I would say the same, that I think we need to have research also looking at sort of the way in which people inhale and the sorts of, you know, the sorts of loss of THC from the way side stream smoke as well as from sharing. But I think, again, we're starting with something, because every time we talked about it in the past, we got to all of these questions that you're bringing up, which you kind of then get lost and sort of throw up your hands. I think we hope that this is a start, and I think that as we get more information, we can certainly try to improve the measures, take into account things like like Delta 8, but I think that you're right. And actually, I don't know if David Hammond is here, but he's also looked at the size of joints, which can be very, very different and changed over time. So, you know, we have a long way to go, but I think really we're looking at this as a starting point, and I think, you know, that's basically what we can offer right now. And if we could at least get people to be starting to use that, then, you know, that would be a big plus.
Great, thank you so much.
Okay. Oh, sorry. Hanan, yeah.
Go to the microphone.
Thanks. Just a question about, so Hanan Abramovich, Health Canada. Just a question around, again, the standard THC unit, and knowing that cannabis can be used for both medical and non-medical purposes. And for medical purposes, the dose of THC, especially the starting dose of THC for a cannabis-naive patient, is not 5 milligrams. It's usually lower than that. It's usually 2.5 milligrams for Marinol, for example, or for Sativex. And we also know from some studies that going even lower than that can actually still be efficacious while minimizing the risk of adverse events. So my question is, in developing a standard THC unit, why not go lower than 5 milligrams and go to 2.5 milligrams or another number that's lower than 5 milligrams, knowing that cannabis can be used for both medical and non-medical purposes, and the evidence suggests that a lower starting dose may be more helpful or useful in certain contexts? Thanks.
It's a great question, and it's a tricky one. If we think about the medical indications, it is important to look at both medical and non-medical use. And that's another challenge for the standard unit. But we do know that data on safety and efficacy and dosing depends on the condition. So whilst we can look at that particular formulation and the starting dose would be 2.5 milligrams moving up to 5 milligrams in most patients, we don't know if that's going to be the case for other medical indications for which cannabis has been studied across a vast array of disorders. So we don't really have a single starting dose for all medical cannabis. And I think we have to work with something that is sensible both for medical and recreational use. But also going back to Amir's point about the capsules that we found when we were in Vancouver, and they had huge number, was it 300 milligrams, Amir? Yeah, so it's a real tricky thing. With cannabis, we see a much wider range from the lowest possible dose to the highest possible dose that we don't see for alcohol. So we're looking at a very wide spread, and that's the kind of thing that we have to grapple with.
Just a note on the 300 milligram claim on illegal products, I would seriously challenge that there's 300 milligrams in those products, and there's a number of studies that have come out recently debunking these high amounts of THC in some of these illicit products. You know, they undoubtedly they can have quite a lot, but they can also say they have 300 when they only have 50 or less. And actually, when in Canada we legalized cannabis, a number of I mean, this is like anecdotal evidence on Twitter, so take it or leave it for what it is, but a number of individuals who were very hardcore cannabis users said that they took a 10 milligram edible and it blew their socks off. And they were very surprised because they never thought that 10 milligrams of THC would actually do anything because they're used to using 300 milligrams of THC. So just cautioning around some of that anecdotal evidence. Thanks.
And rest assured, when Amir and I were in that shop, we did give him a hard time, as you say, so thank you.
Hi, my name is Lydia Johnson-Ferguson. I'm at the University of Zurich. Thank you for your talks. I wanted to ask about hair data, because more and more studies are looking at hair data, and you do get cumulative exposure over 3 months, and you can look at THC and CBD, and you only really detect frequent users. At least that's what we see in a Swiss sample. What's your stance on using that to look at long-term exposure of cannabis use and outcomes? I mean, it's very expensive, so it's probably not feasible as a standardized unit, if I'm not wrong.
Yeah, it's a really good suggestion. And I've done lots of studies with hair samples in cannabis users over the years. And for our research, which started at UCL, one of the reasons we started looking at CBD, led to lots of other studies, was because we found differences in levels of CBD in hair, in particular users. And when matched with THC levels, we saw different psychotic experiences and memory impairment. And so it's something that I've done a lot in previous studies, but we have found over the years that the reliability of the hair measurement is not so good, particularly for cannabinoids. It does tend to be better for other drugs. So it's not something that we're doing so much nowadays, but not to say that the methods can't be refined. But that said, despite the limitations, there aren't any other measures I'm aware of that can give a marker of use beyond, let's say, 1 or 2 months. So hair is perhaps that's its unique advantage as an objective, despite the poor reliability potentially, and that's where it could slot in. But there are problems with the method. Yeah.
And also, there's some evidence suggesting that people with dark hair absorb more THC than people with light hair. So you need to be very careful also for the implications for in the legal system. So people with dark hair might be prosecuted if that is used as evidence as well. So just something to be aware of, hair color.
So that's in a forensic setting, but in a study, would you just suggest controlling for hair color with that?
Possibly. Possibly there's something that needs to be done. Also, if people use hair coloring products, that's the same thing. It can affect the measures. So I would recommend be very clear with whoever runs the analysis and what procedures they have in place. And so use that also to account for it in the data analysis.
Got time for one more question, I think.
Thank you very much. Rosalie Pakula from the United States. Thank you all. I very much enjoyed the work that you are doing. I have a question. You've done a lot. You've gone a lot further than what you presented here today in terms of, I know that your work is going further. Users talk about iatrogenic effects of some of the other terpenes, cannabinoids, and the like. When you think about standardized dose units and 5 milligrams THC, what cannabinoids or other ingredients of cannabis are you concerned about missing in setting those standards? That any work that we know, anything else on the radar?
Well, as I said in my talk, CBD was really the one we were most interested in and enthusiastic about. And over the years, it's not proved to be as fruitful as we had expected. THCV is something that Amir England has done some research on. That's potentially another relevant cannabinoid. But the entourage effect, which is widely used as a way to market cannabis products, is not borne out by the scientific data, at least yet. There's a lot of talk about it, and you could see it that these terpenes are influencing the experience to the consumer in the same way that different wines have different flavors, and they're very important for the consumer in terms of that experience. But the pharmacology and how that would interact with THC, potentially, but it will be a very negligible effect based on what we know at the moment. So. But I'm not sure if others have.
Yeah, I think it's important, as we said before, the concept of standardizing is to go one step forward and be able to get data on quantity that we don't get right now at very low levels. So, for example, primary health care. And when doing this, we acknowledge we are missing a lot of information. As for example, if I ask a person how much he's drinking and he says, I'm taking 3 cups of wine, in Spain I would say, okay, 3 standard drinks, 30 grams of alcohol. And I will not ask if this 12% alcohol, 13% alcohol, 15% alcohol. In the same way, when I ask about how much they smoke, they would say 5 euros, and I would say, okay, that's 4 standard drinks, 4 standard joints. And I know there are much more things there that I'm not controlling, but compared to previously, I start controlling quantity, which is something very relevant when you come to this problem.
I absolutely agree. I think the complexity of cannabis, which goes beyond alcohol, where we're concerned about ethanol, caffeine, which is in a whole variety of forms, nicotine. In cigarettes, we had to worry a little bit about what else was in it. In the case of cannabis, we're concerned about what else do we need to know about in the plant. And I'm just curious, in the development of standard units, to what extent we should be worried about a wild card.
So just one thing, I mean, I don't have an answer to that either. I think, again, we sort of recognize all of the limitations of what this is. But there is a lot of work going on that the National Center for Complementary and Integrative Health is doing on these minor cannabinoids. And so I think that as we start to learn more, it may be possible to incorporate that. But again, we're all kind of at a starting point, which is very much not perfect.
Thanks everyone for very interesting questions. There's a lot of questions to answer. Thanks so much for coming and presenting. Tony, Susan, and Tom, it's been really great to present current challenges and work in progress. Thanks everyone for the great questions, and yeah, I hope you have a good rest of the day at the conference.